is Dr. Chris Fox. Today with the student physical therapist, we're going to talk about assessing the atlantoaxial joint and a little bit of C2-3 as well. So the way that we're going to talk about assessing the AA joint, make sure you've already watched the video on arthrokinematics. It's the understanding of the arthrokinematics and the anatomy in the upper cervical spine really helps you to understand why we do our testing the way it is. For review, remember that the AA joint's primary motion is rotation. While there is a little flexion and extension, there's absolutely no side bending due to the arthrokinematics being made up of condyle on condyle. So side bending is just not possible there. Now, to assess the AA joint, there's a couple different ways that are presented out there. The way we advocate for, to begin, is checking full side bend one way and then rotation the opposite way. The theory being that as you side bend the cervical spine fully to one side, you're locking out C2 and down towards rotation towards the opposite side, so that when you introduce rotation to the opposite side, it can only come from the AA joint. Now, when I do this testing, what I recommend is bring the contralateral shoulder up into a little bit of elevation so that as you side bend, you're not going to get any tension from the scalenes or the upper trap that could restrict end range side bend. So now that I've done that, I'm going to take Jim to end range side bend there. And once I'm there, I'm going to rotate to the right, maintaining that side bend. And what we should have here is about 45 degrees of rotation. A common substitution that I'll see with this is you get them to full side bend and then you just kind of rotate out while not maintaining that side bend. So making sure you hold that will get you a true assessment of the rotation at that joint. And you always want to check with the opposite side as well so that you know your patient's norm. And Jim has a pretty restricted AA joint. All right, the other way that's presented typically in the literature, and probably used more so by the general orthopedic population, is the flexion rotation test. So the way that test is performed is taking the cervical spine into maximum flexion, and while maintaining that, rotate towards each side, looking for a loss of motion. And again, there should be at least about 45, possibly more at this region, but due to potential additional motion, you might get a little bit more. Now this test, the flexion rotation one, is especially good for identifying people with an upper mobility restriction in patients with cervicogenic headaches, particularly picking up a loss of motion of at least 10 degrees of range of motion, one side versus the other. Jim actually felt extremely restricted looking to the left there. Now why we don't advocate for this one for looking purely at AA joint is because in that fully flexed position, as you rotate them towards one side, you can possibly get some C2-3 rotation as well, just as that C2 kind of drops out of maximal flexion on the ipsilateral side. So typically when you go through your testing with this, practice on some of your colleagues and you'll see that your side bend rotation motion tends to be a little bit less than the flexion rotation motion. So it makes us think that you get a little bit of C2-3 as well. Definitely recommend checking these regularly in any of your upper quarter patients, as this is a common area for loss of motion, especially in people with cervicogenic headaches and possibly TMJ dysfunction.